So, good afternoon, Doctor and all of my friends. Let me introduce ourselves. We're from SGDB3, and right now we will try to tell you about chronic lymphoblastic leukemia. Next. So here you go. You can see the member of SGDB3. Next. So hello, my name is Lalita Samala with student number 156, and I'll tell you about introduction of chronic lymphoblastic leukemia. Today, everyone knows what cancer is. Chronic lymphoblastic leukemia is part of cancer. It is malignancy of CD5 plus B cells. It is characterized by increased production of mature but dysfunctional B lymphocytes and resulting in the accumulation of small, mature-appearing lymphocytes in the lymphoid tissue, immunoglobulin, and blood. Genetic factors can involve to the development of chronic lymphoblastic leukemia. Chronic lymphoblastic leukemia is the most common leukemia that happens in adults. In Western countries, the percentage of chronic lymphoblastic leukemia is higher than in Asian countries, approximately 20% to 60% of all leukemia worldwide. These cases can occur between less than 1 and 5.5 per 100,000 people annually, and women are less affected than men. How to know that a patient has this diagnosis? This disease? What are the symptoms and how to diagnose? So in this paper, there will be further information about chronic lymphoblastic leukemia. Next. So here you go. You can see the formulation of problems and purpose. Next. And this is our benefits. Thank you.
Okay, my name is Christopher Yongasa, student number 172. This is table content of our presentation. Next, I'll present an overview of chronic lymphoblastic leukemia. Chronic lymphoblastic leukemia is a type of cancer of white blood cell or lymphoid neoplasm that causes excessive lymphocyte production in bone marrow, and it develops slowly over many years. But lymphocytes that produced in bone marrow are developed abnormally and do not function properly. Next.
Okay, my name is Maria Pramasi Sabrina Fernanda with student number 102. Now I will explain about CLL symptoms, which are lymphadenopathy, marked by swelling in the neck, underarm, stomach, and groin, hepatosplenomegaly, marked by enlarged liver and spleen, night sweats, and persistent fever, frequent infections such as pneumonia, herpes simplex labialis, and herpes zoster, mucocutaneous bleeding such as epistaxis or nose bleeding, and petechiae, weakness, fatigue, and also weight loss.
My name is Cynthia with the 3-digit number 23. So for the pathogenesis is the first one, genetic predisposition. 93% of the susceptibility loci are located in the active promoters or enhancers and modify the binding sites of a number of transcription factors. Example is FOX, NF80, and TCF or LFE, that in turn alter the expression of more than 30 genes involved in immune response, cell survival, or WNT signaling. Thank you.
So hello, my name is Jeremy with student number 083. I'm going to explain about the cell of origin. Hematopoietic stem cells derived from patients with CLL express higher levels of transcription factors than from healthy donors, which is alluring if some susceptibility loci increase TCF3 binding or ERF8 expression. Mutations in driver genes such as NOTCH1, SF3B1 may be acquired by hematopoietic stem cells. The last one is genomic structural aberrations. Initial chromosome binding analysis revealed that deletions or trisomies were relatively common but only observed in fewer than half of the patients. With the advent of fluorescence in situ hybridization or FISH, genomic aberration were identified for more than 80% of patients, the more relevant being trisomy 12, 13q deletion, 11q deletion, and 70p deletion. And FISH became the gold standard for genomic evaluation in CLL. Thank you.
Okay. My name is Dandi Prema with last student number is 182. Next is about the risk factors of chronic lymphoblastic leukemia. Certain risk factors for the development of CLL are identified. So the first one is age. The risk of getting CLL increases with age. CLL is most common in people over 60 years of age. The second one is gender. CLL is more common in men than in women. The third one is family history. Family history of CLL or blood and lymph system cancer also have a risk of getting CLL. The fourth one is ethnicity. People who have relatives who are Eastern European Jews or Russian Jews have a greater risk of getting CLL. The fifth is chemical exposure. People exposed to Agent Orange, an herbicide used in the Vietnam War, have a greater risk of contracting CLL. So that's all the risk factor of CLL. Thank you.
Hello, my name is Wilson Alim, student number 149. So I will present about the diagnosis of chronic lymphoblastic leukemia. The first one is at the time of diagnosing CLL patient, most patients are asymptomatic and can be detected as having CLL when lymphocytosis is found in the routine blood count. The second one is the abnormality that is often found is an increase in the number of lymphocytes up to 10,000 cells per microliters. With having or developing enlarged lymph nodes, hepatomegaly and splenomegaly, which are palpable on physical examination. Enlarged lymph nodes can be easily palpable at three sites: the cervical, axillary, and inguinofemoral regions. And the last one is laboratory tests that can be used, such as CBC, flow cytometry, bone marrow biopsy, or bone marrow aspiration. Thank you.
Hello, my name is Chris Julia, with the student number is 118. There are two staging systems that divide CLL patients into three prognostic groups. The two staging systems are first the RIA staging and second Binet classification. Next. The RIA staging commonly used in United States. It has three groups. First is low risk with lymphocyte without cytopenia, lymphadenopathy, or splenomegaly with the life expectancy is 13 years. And second is intermediate risk with the lymphocytosis, lymphadenopathy, or splenomegaly but without cytopenia with the life expectancy is 8 years. And the last is high risk with the life expectancy is only 2 years. Thank you.
Hello, my name is Wulan and my number is 010, and here I will explain to you about the Binet classification, which is more common in European countries. So Binet classification group patients into low risk as stage A, intermediate risk as stage B, and high risk as stage C. Clinical feature in stage A is less than 3 probably enlarged sites without cytopenia with median life expectancy of 13 years. In intermediate risk, there are 3 or more probably enlarged sites without cytopenia with median life expectancy of 8 years. And in high risk group, there are cytopenia with median life expectancy of 2 years. And there's also differential diagnosis, which include ALL, acute promyelocytic leukemia, diffuse large cell lymphoma, follicular lymphoma, hairy cell leukemia, mantle cell lymphoma, and many more. Thank you.
My name is Nicole Puntario with student number 065. So the treatment and management is divided into 3 groups. The first group is for fit patient. The treatment is chemoimmunotherapy with fludarabine, cyclophosphamide, and rituximab or FCR for the young fit patient, and bendamustine combined with rituximab or BR for fit elderly patient. Although BR is less effective, it is less myelosuppressive than VCR. Next is group 2, is patient with relevant comorbidities. The treatment is chlorambucil. Despite its advantage, chlorambucil has some disadvantages after extended use. And the third group is patient with DEL17P or a TP3 mutation and has only one effective therapy and can cause serious infectious complication. The therapy is anti-CD42 antibody, alemtuzumab or HSCT. Thank you.
Thank you for the time. My name is Joshua with 3-digit number 035. There are several complications of chronic lymphoblastic anemia or CLL. One of them is infectious complications that is the most common complications of CLL. The range of these infectious complications has evolved alongside the therapeutic advances in CLL treatment. Aside from infectious complications, CLL can cause kidney disease as a manifestation of the disease process such as kidney injury, extrarenal obstruction, and tumorolysis syndrome. Lastly, CLL can also cause several autoimmune complications, particularly autoimmune hemolytic anemia and immune thrombocytopenia, complicate up to 25% of CLL cases. These complications seem to advance in correspondence with advanced stage CLL and with poor prognostic markers. B lymphocytes and T lymphocytes that are thought to be responsible of these pathogenic complication mechanisms that can also cause Richter syndrome.
Thank you for the opportunity. My name is Jonathan Edmund with student number 137. So the initial prognosis of CLL can be determined by the characterization of the tumor itself. Other than that, correlation with mutational status are used instead of where CD38 and ZAP270 that are examined using flow cytometry and immunohistochemistry. Increase of the mentioned findings may correlate with poorer prognosis, but the examination of CD38 and CD8p70 are still controversial. Findings of chromosome 17p13 can be used to monitor prognosis of CLL, and the deletion of the chromosome can also predict resistance to chemoimmunotherapy. As mentioned, RAI and BNET can be considered as clinical staging system that can give information about the prognosis of the disease. Where RAI staging can give clinical staging through evaluation of patients who experience lymphocytosis with leukemia cells in the blood, where the stage 1 with good prognosis have incidence of lymphoid cells more than above 30%, with higher stages showing poorer prognosis. While BNET staging system is evaluated by the number of areas involved, with more enlarged lymph node with size greater than 1 centimeter shows bad prognosis. Next.
My name is Utayu Pratnyani with the last number 222. So, in the conclusion, chronic lymphoblastic leukemia is a type of cancer of the white blood cell or lymphoid neoplasm that develops slowly over many years, characterized by a progressive accumulation of functionally incompetent lymphocytes that develop in the bone marrow and lymph nodes. CLL can cause by genetic predisposition, hematopoietic cell, the B receptor cells, and the structural pneumonic aberration. Some of clinical symptoms may appear such as fatigue, unintentional weight loss, excessive night sweat, and early feeling fullness in stomach, and increased risk of infection. Some laboratory assessments include complete blood cell count and flow cytometry are used to confirm CLL in patient. Treatment for a patient with CLL can be divided into 3 groups. The first group can be treated with cellular therapy. The second group goal is to control the disease with dose reduced or modified therapy. And the third group goals is the same as the second group, but with the best therapy by using anti-CD52 antibody amitriptyline as a treatment. There are several complications of CLL, include kidney disease, several autoimmune complications, particularly autoimmune hemolytic anemia and immune thrombocytopenia. I think that's all of our presentation, and thank you.